The effectiveness of mobile health technology-based health behavior change or disease management interventions for healthcare consumers, a systematic review. Abstract. Background. Mobile technologies could be a powerful media for providing individual-level support to healthcare consumers. We conducted a systematic review to assess the effectiveness of mobile technology interventions delivered to healthcare consumers. Methods and findings. We searched for all controlled trials of mobile technology-based health interventions delivered to healthcare consumers using Medline, Embase, Sysinfo, Global Health, Web of Science. Cochrane Library, UK NHS, January 1990, September 2010. Two authors extracted data on allocation concealment, allocation sequence, blinding, completeness of follow-up, and measures of effect. We calculated effect estimates and used random effects meta-analysis. We identified 75 trials. 59 trials investigated the use of mobile technologies to improve disease management, and 26 trials investigated their use to change health behaviors. Nearly all trials were conducted in high-income countries. 4 trials had a low risk of bias. 2 trials of disease management had low risk of bias. In 1, antiretroviral (ART) adherence, use of text messages reduced high viral load greater than 400 copies, with a relative risk (RR) of 0.85, 95% C 0.72, 0.99. But no statistically significant benefit on mortality (RR 0.79, 95% CI 0.47, 1.32). In a second, UPNA-based intervention increased scores for perceived self-care agency in lung transplant patients. 2 trials of health behavior management had low risk of bias. The pooled effect of text messaging smoking cessation support on biochemically verified smoking cessation was RR 2.16, 95% CI 1.77, 2.62. Interventions for other conditions showed suggestive benefits in some cases, but the results were not consistent. No evidence of publication bias was demonstrated on visual or statistical examination of the funnel plots for either disease management or health behaviors. To address the limitation of the older search, we also reviewed more recent literature. Conclusions. Text messaging interventions increased adherence to ART and smoking cessation and should be considered for inclusion in services. Although there is suggestive evidence of benefit in some other areas, high-quality adequately powered trials of optimized interventions are required to evaluate effects on objective outcomes. Please see later in the article for the editor's summary. Editor's summary. Background. Every year, millions of people die from cardiovascular diseases, diseases of the heart and circulation, chronic obstructive pulmonary disease, a long-term lung disease, lung cancer, hive infection, and diabetes. These diseases are increasingly important causes of mortality, death, in low and middle-income countries, and are responsible for nearly 40% of deaths in high-income countries. For all these diseases, individuals can adopt healthy behaviors that help prevent disease onset. For example, people can lower their risk of diabetes and cardiovascular disease by maintaining a healthy body weight, and, if they are smokers, they can reduce their risk of lung cancer and cardiovascular disease by giving up cigarettes. In addition, optimal treatment of existing diseases can reduce mortality and morbidity, illness. Thus, in people who are infected with hive, antiretroviral therapy delays the progression of hive infection and the onset of AIDS, and in people who have diabetes, good blood sugar control can prevent retinopathy, a type of blindness, and other serious complications of diabetes. Why was this study done? Healthcare providers need effective ways to encourage healthcare consumers to make healthy lifestyle choices and to self-manage chronic diseases. The amount of information, encouragement and support that can be conveyed to individuals during face-to-face consultations or through traditional media such as leaflets is limited. But mobile technologies such as mobile phones and portable computers have the potential to transform the delivery of health messages. These increasingly popular technologies, more than 2/3 of the world's population now owns a mobile phone, can be used to deliver health messages to people anywhere and at the most relevant times. For example, smokers trying to quit smoking can be sent regular text messages to sustain their motivation, but can also use text messaging to request extra support when it is needed. But is health, the provision of health-related services using mobile communication technology, an effective way to deliver health messages to healthcare consumers? In this systematic review, a study that uses predefined criteria to identify all the research on a given topic, the researchers assess the effectiveness of mobile technology-based health behavior change interventions and disease management interventions delivered to healthcare consumers. What did the researchers do and find? The researchers identified 75 controlled trials, studies that compared the outcomes of people who do and do not receive an intervention of mobile technology-based health interventions delivered to healthcare consumers that met their predefined criteria. 26 trials investigated the use of mobile technologies to change health behaviors, 59 investigated their use in disease management, most were of low quality, and nearly all were undertaken in high-income countries. In one high-quality trial that used text messages to improve adherence to antiretroviral therapy among HIV-positive patients in Kenya, the intervention significantly reduced the patient's viral load but did not significantly reduce mortality. The observed reduction in deaths may have happened by chance. In two high-quality UK trials, a smoking intervention based on text messaging, Text to Stop, more than doubled biochemically verified smoking cessation. Other lower-quality trials indicated that using text messages to encourage physical activity improved diabetes control but had no effect on body weight. Combined diet and physical activity text messaging interventions also had no effect on weight, whereas interventions for other conditions showed suggestive benefits in some but not all cases. What do these findings mean? These findings provide mixed evidence for the effectiveness of health intervention delivery to healthcare consumers using mobile technologies. Moreover, they highlight the need for additional high-quality controlled trials of this health application, particularly in low- and middle-income countries. Specifically, the demonstration that text messaging interventions increased adherence to antiretroviral therapy in a low-income setting and increased smoking cessation in a high-income setting provides some support for the inclusion of these two interventions in healthcare services in similar settings. However, the effects of these two interventions need to be established in other settings, and their cost-effectiveness needs to be measured before they are widely implemented. Finally, for other mobile technology-based interventions designed to change health behaviors or to improve self-management of chronic diseases, the results of this systematic review suggest that the interventions need to be optimized before further trials are undertaken to establish their clinical benefits. Introduction. Each year, worldwide, over 22 million people die from diseases such as cardiovascular disease, chronic obstructive pulmonary disease, HIV, lung cancer, and diabetes mellitus. The majority of deaths, 83%, occur in low- and middle-income countries. However, these are also important causes of mortality in high-income countries, accounting for about 39% of deaths. Healthcare consumers adopting healthy behaviors can prevent the onset of many of these leading causes of mortality. 10 years after stopping smoking, the risk of lung cancer is half of that of those continuing smoking, and 15 after stopping smoking the risk of cardiovascular disease is similar to that of those who never smoked. HIV can be prevented by adopting safer sexual practices. In people who are overweight, weight loss can reduce the incidence of diabetes. Optimal treatment of existing diseases can also reduce mortality and morbidity. In patients with existing coronary heart disease, long-term antiplatelet therapy reduces major vascular events, myocardial infarction, stroke, or vascular mortality by about a quarter. ACE inhibitors reduce cardiovascular mortality by just under a fifth, beta blockers reduce mortality by almost a quarter, and lipid-lowering therapy reduces coronary mortality by about a fifth. Antiretroviral medication delays the progression of HIV infection. Good control of diabetes reduces the onset of retinopathy by half and reduces the onset of nephropathy by 2/3. Optimal treatment of existing diseases requires the involvement of healthcare consumers in managing aspects of their disease. Healthcare consumers decide whether to adhere to prescribed medication and determine when they seek healthcare. involving healthcare consumers in self-management of diseases such as in monitoring their health disease status and adjusting their medication dosage. For example, insulin or asthma medications can improve health outcomes. An important function of healthcare services is therefore to encourage and support healthcare consumers to adopt healthy behaviors and to self-manage chronic diseases. However, the amount of information, encouragement, and support that can be conveyed during consultations, with an existing service infrastructures or through other traditional media, such as leaflets, is limited. Mobile technologies are a means for providing individual-level support to healthcare consumers. Mobile health interventions for healthcare consumers have been designed to increase healthy behavior, for example, to increase smoking cessation or activity levels, or improve disease management, for example, by increasing adherence to prescribed medication, improving management of diabetes or asthma, or delivering therapeutic interventions. Mobile technologies include mobile phones, personal digital assistants, DAS, and phones, for example, BlackBerry, Palm Pilot, smartphones, for example, iPhone, enterprise digital assistants, EDAs, portable media players, that is, MP3 players, MP4 players, for example, iPod, handheld video game consoles, for example, PlayStation Portable, PSP, Nintendo DS, handheld and ultra-portable computers such as tablet PCs, for example, iPad, and smart books. These devices have a range of functions from mobile cellular communication using text messages, SMS, photos and video, MMS, telephone, and World Wide Web access, to multimedia playback and software application support. Technological advances and improved computer processing power mean that single mobile devices such as smartphones and phones are increasingly capable of high-level performance in many or all of these functions. The features of mobile technologies that may make them particularly appropriate for providing individual-level support to healthcare consumers relate to their popularity, their mobility, and their technological capabilities. The popularity of mobile technologies has led to high and increasing ownership of mobile technologies, which means interventions can be delivered to large numbers of people. In 2009, more than two-thirds of the world's population owned a mobile phone, and 4.2 trillion text messages were sent. In many high-income countries, the number of mobile phone subscriptions outstrips the population. In low-income countries, mobile communication technology is the fastest-growing sector of the communications industry and geographical coverage is high. Mobile technologies are mobile and popular, such that many people carry their mobile phone with them wherever they go. This allows temporal synchronization of the intervention delivery and allows the intervention to claim people's attention when it is most relevant. For example, healthcare consumers can be sent messages designed to sustain their motivation to quit smoking throughout the day. Temporal synchronization of the intervention delivery also allows interventions to be accessed or delivered within the relevant context, that is, the intervention can be delivered at any time and extra support can be requested wherever and whenever it is needed. For example, smokers trying to quit can send text messages requesting extra support while they are experiencing cravings due to withdrawal from nicotine. Or those with asthma can access advice regarding how to increase the use of inhalers during an exacerbation of asthma. The technological capabilities of mobile technologies are continuing to advance at a high pace. Current technological capabilities allow low-cost interventions. There are potential economies of scale as it is technically easy to deliver interventions to large populations. For example, mobile technology applications can easily be downloaded and automated systems can deliver text messages to large numbers of people at low cost. The technological functions that have been utilized for healthcare consumers include text messages, SMS, software applications, and multiple media, SMS, photos, interventions. The technology supports interactivity, which allows people to obtain extra help when needed. Motivational messages, monitoring, and behavior change tools used in face-to-face support can be modified for delivery via mobile phones. Interventions can be personalized with the content tailored to the age, sex, and ethnic group of the participant or to the issues they face. Existing systematic reviews of mHealth interventions focus on the application of specific devices, for example, mobile phones, specific mobile technology functions, for example, text messaging, or individual diseases or types of illness, for example, diabetes care or chronic disease management. These reviews require updating. Some types of interventions for healthcare consumers targeting healthy behavior or disease management have not been covered by previous reviews. A comprehensive review of interventions delivered to healthcare consumers is lacking and provides a valuable overview of the existing evidence. This systematic review aimed to quantify the effectiveness of mobile technology-based interventions delivered to healthcare consumers for health behavior change and management of diseases. Methods. We adhere to our published plan of investigation as outlined in the study protocol. Participants were men and women of any age. We included all controlled trials employing any mobile technology interventions, mobile phones, BTAs and phones, for example, BlackBerry, Palm Pilot, smartphones, for example, iPhone, enterprise digital assistants, EDAs, portable media players, that is, MP3 players and MP4 players, for example, iPod, handheld video game consoles, for example, PlayStation Portable, PSP, Nintendo DS, handheld and ultra-portable computers such as tablet PCs, for example, iPad and smartbooks, to improve or promote health or health service use or quality. Trials were included regardless of publication status or language. We included studies in which the intervention delivered by mobile technology was the primary intervention component under evaluation. We excluded studies evaluating either mixed mobile technology and non-mobile technology-based interventions in which the treatment and control group both received the mobile technology-based component or interventions in which treatments between the treatment and control groups differed in additional ways besides the components delivered by mobile technology, such as interventions involving face-to-face counseling with a text message intervention compared to a control group receiving information only. We included trials of immunization reminders. Trials of general appointment reminders are reported elsewhere. The interventions in trials meeting the inclusion criteria and targeting health behavior change or disease management interventions for healthcare consumers are reported here. Other trials identified targeted data collection or healthcare delivery processes, such as those directed to healthcare providers, for example, for diagnosis and management, or those involving communication between healthcare services and healthcare consumers, for example, appointment reminders, test result notification. These are reported in two separate articles, 33. No trial was excluded from the review based on the type of health or healthcare service targeted. Primary outcomes were defined as any objective measure of health or health service delivery or use. Secondary outcomes were defined as the following: self-reported outcomes related to health behaviors, disease management, health service delivery or use, and cognitive outcomes. Outcomes reported for any length of follow-up were included. We searched the following electronic bibliographic databases: Medline, Embase, Sysinfo, Global Health, the Cochrane Library, Cochrane Database of Systematic Reviews, Cochrane Central Register of Controlled Trials, Central, Cochrane Methodology Register, NHS Health Technology Assessment Database, and Web of Science, Science and Social Science Citation Index from 1990 to September 2010, and the reference lists of included trials. The list of subheadings, mesh, and text words used in the search strategy can be found in Text S3. All of these terms were combined with the Cochrane Library Medline filter for controlled trials of interventions. 2 reviewers independently scanned the electronic records to identify potentially eligible trials. 2 reviewers independently extracted data on number of randomized participants, intervention components, mobile devices employed, mobile technology functions used, sequence generation, allocation concealment, blinding of outcome assessors, completeness of follow-up, evidence of selective outcome reporting, any other potential sources of bias, and measures of effect using a standardized data extraction form. The authors were not blinded to authorship, journal of publication, or the trial results. All discrepancies were agreed by discussion with a third reviewer. The behavior change techniques used in behavior change interventions were classified according to Abraham and Michie's taxonomy of behavior change techniques. 34. Risk of bias was assessed according to the criteria outlined by the International Cochrane Collaboration. 35. We assessed blinding of outcome assessors and data analysts, and we used a cutoff of 90% complete follow-up for low risk of bias for completeness of follow-up. We contacted study authors for additional information about the included studies, or for clarification of the study methods as required. All analyses were conducted in STATA V11. We calculated risk ratios and standard mean differences. We used random effects meta-analysis to give pooled estimates where there were 2 or more trials using the same mobile technology function, for example, SMS messages, and targeting the same disease, for example, diabetes control, or behavior, for example, activity, and reporting the same outcome.
We examined heterogeneity visually by examining the forest plots and statistically using both the Chi2 test and the I2 statistic. We assessed evidence of publication bias using funnel plots. Results. The combined search strategies identified 26,221 electronic records, which were screened for eligibility, Figure 1. The full texts of 334 potentially eligible reports were obtained for further assessment. Out of the 334 potentially eligible reports, 75 met the study inclusion criteria and were trials delivered to healthcare consumers. 26 interventions aimed to increase healthy behaviors, such as stopping smoking or increasing activity, which can prevent the onset or progression of disease, health behavior change interventions. And 49 targeted disease management, including interventions designed to improve self-management of diseases like diabetes, and therapeutic interventions, such as interventions providing psychological support. Hope you enjoyed the video. Please like, share and subscribe. For more info refer to the video description.